All right, and we're ready.
Okay, thank you, Jeffrey, and good afternoon to everyone. Thank you for joining us in this breakout sessions on disparities in healthcare. And it's my privilege, I guess, to talk to you about Indigenous health. And I'm going to use a specific example of the Indigenous Cancer Journey and look at the truth about this pathway and some of the ways to reconcile our findings and way to make this cancer journey better for Indigenous patients. As Jeffrey mentioned, I'm Jason Pennington. I'm a general surgeon at the Scarborough Health Network, and I would like to first greet you by saying Kwe Kwe Ataro. Welcome to our virtual circle of friends. That's a greeting in my Huron-Wendat native language. My community is Wendake, it's just north of Quebec City. This is also my disclosure slide. So hence I am a member of the Huron-Wendat Nation, and that might make me somewhat biased in my points of view. I'm also, as mentioned previously, a general surgeon. So maybe I have a surgical slant to my point of view. And I am the Regional Indigenous Cancer Lead for the Central East Regional Cancer Program here in Ontario. Which I might have drunk a little too much of the Cancer Care Ontario Kool-Aid, but I don't think the CEO believes that. So with that, I would like to continue by acknowledging, I noticed in the pamphlet, in the literature for the conference that you do make an acknowledgement, which is totally appropriate. And the land, I'm just going to do it from where I am sitting here in Scarborough right now, and the land on which U of T operates has been the site of human activity for thousands of years. This land is the traditional territory of the Wendat, Petun, Seneca, and most recently the Mississaugas of New Credit. The territory was subject to the Dish with One Spoon Wampum Belt Covenant, which is an agreement to peaceably share the resources around the lower Great Lakes and St. Lawrence. Today, South Central Ontario is the home to many Indigenous peoples from across Turtle Island, and we're grateful to have the opportunity to work in the community and on this important traditional territory and meeting place. And of course, the reason we do an acknowledgement isn't just to note things, but it's to take a moment to reflect and see how the people before us left us this territory, this land, these resources, and this knowledge in a good space so that we could be thriving here today, and that we should be doing the same, trying to gain knowledge from our meetings today so that we can better the care for our patients, our colleagues, and for the 7 generations to come. The objectives of the talk are going to be first to review the cancer journey with a focus on colorectal cancer, to examine the historical and current health status of Indigenous peoples with specifics around cancer and colorectal cancer, to understand the social determinants of Indigenous health, which is a bit different model from the one you're used to, and appreciate how they can impact the Indigenous cancer journey, and then to gain insight into various methodologies, actions that we can use to mitigate the impacts of these social determinants. So to start off with the very basics, what is cancer, right? Everybody hears cancer, and I don't know how advanced in your trainings and what programs you are all from, but cancer is cells that have just started to grow out of control. And this can happen in various ways, and it can happen in every different cell type in your body. So it is actually a whole group, it's actually several hundred different diseases, and that makes it very different, right? Everybody hears that C word, and it's all laden with the same fear and the same visceral response. But in a way, it's just like the V word, virus. And people can have a virus that's the common cold. People can have a virus that's COVID or SARS. People can have a virus that's Ebola. And people can have a virus that's something like HIV that we can control and basically turn into a chronic disease nowadays. So the same with cancer is that some are very indolent, and they probably don't need very little treatment, or they're very easy to treat, whereas others are unfortunately very aggressive and very hard to control and quite life-threatening within a matter of weeks to months. So it's a very diverse group of diseases. In that realm, there is colorectal cancer, which is an adenocarcinoma, a cancer of the gland cells throughout the colon and rectum. And as you can see on the picture, the colon and rectum form like a picture frame going all around the outside and across the top and back down and out of your intestines and your abdomen. And it is cells in the lining of the bowel that grow out of control. And we believe, this isn't a course in pathology, but we believe that really to progress to become a cancer, it goes through a polyp phase and gets, it takes a series of possibly up to 10 years of going from a baby adenomatous polyp to becoming a true invasive cancer. It takes a 10-year, and it's not a sure thing, right? It takes 10 years, 6 different mutations have to occur. And, usually goes from being an adenomatous polyp, tubular adenoma, tubulovillus, dysplasia, cancer. So it doesn't happen overnight. And there are 4 stages. Well, here they added a 0, but it isn't really cancer yet, truly at stage 0. But stages 1 and 2 are purely in the bowel wall, and it depends on how many layers it goes through in the bowel wall. As you see in stage 2, it's into those muscle layers. In stage 3, it has spread to the lymph nodes, and in stage 4, it is spread to other organs, which for colorectal cancer is usually the lungs or the liver. And the thing about colorectal cancer is that stage means everything, and then you'll see why that's important in a little while. But stage 1, 90% chance you're cured by just doing an operation and taking out the tumor cleanly. Stage 4, you'll probably live 2 years. Median survival is stage 4 colon cancer is still a couple years with all the treatments. We can slow things down, but 90–95% chance we can't cure you, get you a cure. So it's like the opposite of that stage 1 tumor, right? 90% cure, 90% non-cure. So a big, big difference in outcomes depends on what stage we find it at. And that's why colorectal cancer is somewhere in the middle of those indolent tumors, cancers, and those very aggressive ones, right? Whereas there are some that are very treatable and people do very well, and then others not so much. So this is just a picture of the cancer journey. Once you're on the cancer journey for colon cancer, it starts with prevention and screening, and we'll mention a little more about that as we go on. But, diagnosis, the treatment can also be somewhat extended, right? Treatments for colorectal cancer, if it's very early, often just an operation, but if it's more involved or if it is rectal cancer, which is a little different entity from colon cancer because of anatomy and the structures that are all packed in that area down in the pelvis, it often requires a combination of radiation and chemotherapy and as well as surgery, and sometimes small surgeries, defunctioning stomas, and then bigger operations, and then reversing. So these journeys can take just a year of treatments, of various treatments. So it's not always so straightforward. And then we go into the, no one ever is truly over their cancer, even if they're cured and have no visible disease, there's always survivorship. And unfortunately, we do have people that end up going towards the palliative route. So where does this play with Indigenous people? Well, I first want to just mention the health status of Indigenous people at the time of contact. And this is somewhat important because, we have to deal with the realities of now, but we also have to see of why that has changed, because this is a picture of Jacques Cartier on his second voyage, meeting some Indigenous people, although I don't think that's a headdress that we wore in the Eastern Woodlands, but nonetheless, whether it was Jacques Cartier, Christopher Columbus, or Samuel de Champlain, they all recorded in their ship's diaries how the people they met in North America were all in good health and strong and vibrant and basically living quite healthily over here, especially when compared to having done a sea journey across the Atlantic in a rickety wooden boat. I'm sure the people here looked very well. And had quite a good knowledge of the agriculture for the area, the hunting, the medicines. They actually had a cure for scurvy, right? And so they had a good health status some 400 years ago, by all accounts. And I won't get into the scurvy story more than that for this discussion. And relationships were kind of healthy. This is one of the first wampum belt, or a depiction of one of the first wampum belts between the Dutch and the Haudenosaunee, or people of the Longhouse, around 1613. They made an agreement, and it was showed two parallel lines. There were some purple shells, two rows running in parallel, one a canoe, one a sailing ship. And they're supposed, the three lines between them were supposed to represent friendship and peace and respect. And as you see, they're supposed to go from the past forward into the future, and they're supposed to share and help each other. But like parallel lines, they're not supposed to meet. They're not supposed to interfere with each other. And so that was a description of a healthy relationship that was supposed to be formed. But even one of the indigenous chiefs at the time noted that the Europeans didn't really seem to get the pact, and that they were treating the indigenous side of the negotiations more as children than as an equal brother or partner. But that being said, obviously many things have happened in the 400 years with famines, plagues, illnesses of various sorts, and pandemics, and treaties not being honored. And we could go through all this. There could obviously be there are whole university courses on each of these, but I just want to mention two specifics, because there are two acts in those 400 years that really do impact every single indigenous person and family in the country. And one of these is the Indian Act from 1876. So Canada is barely, 9 years old. And it's actually the consolidation of several pieces of legislation pertaining to indigenous peoples in North America. And they were based, two of them that they were based upon were the Gradual Civilization Act and the Gradual Enfranchisement Act. So you can see that really they are acts of try to civilize the uncivilized, right? Declaring that indigenous people were uncivilized, when truly they had true agriculture, architecture, science, and even medicines at the time of contact. But the whole error of terra nullius, which was even propagated by the Pope at the time of contact, really made indigenous peoples non-entities and really non-people because they were not equal on a basis of civilization, which was totally false. But that being said, the whole act of this act is to remove indigenous peoples and indigenous cultures and indigenous language. And it did so with two main processes. One was by setting up reserves, which kept indigenous people in very small territories, got rid of a lot of the territories that they used to use, because a lot of their traditional acts of hunting and trapping and fishing really require large territories or following herds. And as well, once you're on that territory, you had to get permission to leave. So if you were having a successful business, making moccasins, making any other kinds of crafts or growing any produce, and you wanted to sell it in a nearby town, you weren't allowed under this act. So you could only feed your small population in your reserve. So there's no way to build your business and get ahead. If you wanted to do business outside, you had to disenfranchise, give up your status. There's no other group of Canadians that's had to give up their identity, their religion, their language in order to be able to practice or get a profession in Canada. If you wanted to go to university and study law or engineering or law, medicine, you had to disenfranchise once again. So if you were trying to do anything to better yourself or to better your community, you were forced out of your culture and your people. Also, there were rules around so from the reserves, and there's rules around who had actual Indigenous status. Plus, there was the patriarchal aspect of this. And for my culture, which is very matriarchal, your clan designation goes on the on the maternal line. Like, you would have family, if a Indigenous woman married a non-Indigenous man, she lost her status and their children weren't Indigenous. Whereas the inverse was true. If an Indigenous man married a non-Indigenous woman, she became Indigenous. Kind of a pretty amazing thing that you can do. But, and of course, in families where the clan was designated by the mother, this broke up families, broke up clans, also would make lots of family discord, right? Because people would feel, cause rifts between brothers and sisters because one's children were considered Indigenous and another's weren't. One could succeed where another wouldn't. And, and the other issue that went on is the residential schools and the 60s scoop. And I think you have to say the 60s scoop because, and even the whole society in the era, in the 50s and the 60s, was really harsh on Indigenous people, even those that didn't attend the actual residential schools. But it does look, and to call them residential schools is really a misnomer, because residential schools, there wasn't much reading, arithmetic, or writing going on. They were really just trying to relegate the Indigenous culture and language from these students, right? Their hair was shorn, their clothes were, any traditional clothes were removed, hence Orange Shirt Day, and they were forced not to practice their language or culture. So it was really to assimilate Indigenous peoples. But the worst part was even more, and of course, the physical, mental, sexual abuse, and then poor coping mechanisms to go with it, but also just that fact of growing away from your family, from your community, and never having examples of hugs or love being expressed to you while you grow up. Then when you become an adult and have poor coping mechanisms for this, and your child is coming to you and you don't have the right mechanisms and you've never been hugged yourself, this propagates and becomes intergenerational trauma. And nearly every Indigenous family in Canada struggles in some way with the process of these intergenerational traumas that have gone on to our families and relatives going back several generations now. And it expresses itself in many different ways. The same ways as when someone gets a cancer diagnosis, some people, respond to that getting very angry, others get very sad, others are very resilient and defiant. The same with Indigenous people, right? Every person, every family, every community has responded in various ways, but it does affect us all, this history. So what has happened over the 400 years? Well, life expectancy for Indigenous Canadians is still 5 to 7 years less than the Canadian average. Obesity, diabetes, smoking, substance abuse, trauma, major depression, and suicide are all 2 to 4 times the national average, sometimes many, many times that when on specific reserves or in very rural and remote areas. So a lot of these things you've probably seen before: the diabetes, the depression, the suicide, the smoking, obesity, all of these get mentioned quite a bit in various health circles, public health circles. And we don't really think of cancer as an Indigenous disease. In fact, some people actually believe in the Indigenous community that cancer was not a problem for them, right? Not really seen of, especially when we're dealing with so many other health issues. So over time, CCO, Cancer Care Ontario, and the Chiefs of Ontario have come together to look at the ISIS data, that's the clinical experience data that's collected in Ontario, and have made agreements to use it in a good way. Because the numbers that were out there were pretty poor, but even from the late 70s, running through the 80s and 90s, with very poor data, because it was very hard to identify Indigenous patients and there wasn't a lot of cooperation. But basically, it did show that Indigenous cancer rates incidence was lower than the provincial average. But as things gone on, we've seen a pretty worrisome trend, and the news is not really good. So we used to have a lower incidence, but now Indigenous Ontarians have essentially caught up with the overall cancer incidence in Ontario. We Indigenous Ontarians have the same top 3 cancers as the general Ontario population. We actually have a higher incidence of lung and colon cancer, but a lower incidence for breast and prostate cancer as compared to the provincial average. Even more worrisome than the incidence is that our outcomes are worse. We have worse outcome, mortality, and 5-year survival on most different cancer fronts. Sometimes these are statistically significant, but often they aren't. Basically, that's usually based on, you don't have enough numbers to make it statistically significant, but our outcomes are worse. So now we've caught up in incidence and we're doing worse on outcomes. So not very good. When we look specifically at colorectal cancer in Ontario First Nations, it's the second most diagnosed cancer among First Nations in Ontario. We have a significantly higher incidence in First Nations, and males have more than females, which is the same as in the Ontario population. Significantly higher mortality for Indigenous Ontarians with colorectal cancer, and the 5-year disease-free survival is lower, but it's not statistically significant. Again, one of those statistic, games of playing with numbers and having enough people in a group to make statistical significance. But so we actually have a higher incidence of colorectal cancer and poorer outcomes. This is an interesting slide that I often throw in, and it talks about cancer survival in Australia. It's interesting for us. So it showed that significantly worse survival overall for Indigenous patients, but they had a very interesting tidbit, at least from my surgical point of view, is that for colorectal cancer, Indigenous patients, they were just as likely to receive surgery, but had a significantly decreased survival. So this information is a bit interesting from a couple fronts. One, it does confirm, and you do see it in studies across different provincial jurisdictions and also across different Indigenous populations around the world that have faced colonization, is that outcomes in cancer care are often worse. But also from a surgical point of view, our surgery training, I don't think any surgeon provides care or does surgery differently for one colorectal cancer patient versus another. We're pretty simple beasts. We learned the proper way to do a colorectal cancer surgery. There's certain principles. You might not always do them in the same order, but you want to get clear margins, take at least 13 12 to 13 lymph nodes, do a proper mesorectal excision when you're doing cancer surgery. We follow these rules, right? This is the way we do it. It's a mantra, it's practiced over and over during your residency. So why is this survival decreased? And the study wasn't set up to really look at this, so they don't have all the reasonings, but one of the most easy ways to think about it is probably, as we mentioned earlier, in colon cancer, for survival, stage is everything. So probably Indigenous people are coming to their diagnosis and their surgery at a higher stage. And therefore, the outcomes are going to be curtailed. So what determines your stage at the time of diagnosis? And there's 2 things that are going to affect that. Those are your risk factors, or your preventative measures that you could have taken, and your screening. Were you getting diagnosed before you had symptoms? Because we know if you're diagnosed with symptoms, you're on average at a higher stage than someone who's diagnosed because of screening. So when the Métis Nation of Ontario and Cancer Care Ontario, they made an agreement and started to look at some of these things. They looked at exactly that. They looked at risk factors, smoking, alcohol, obesity, and physical activity. And the first 3 all were significantly increased in Métis Ontarians compared to non-Aboriginal Ontarians. Physical activity was not statistically significantly different, but unfortunately, physical activity was very poor for all Ontarians. So nothing to be proud of, Ontario. We're all really lazy. And also when it came to cancer screening, Métis Ontarians were less likely to be up to date with their cancer screening tests when compared to non-Aboriginal Ontarians. So we had worse prevention, higher risk factors, and decreased screening. So at the time of diagnosis, if you're a stage 3 versus a stage 2, if it's gone to your lymph nodes, 70%, 2/3 chance, no lymph nodes, 2/3 chance it won't come back. If your lymph nodes are positive, 2/3 chance it does come back. So it's a flip from 33 to 66. That's a huge difference in the way, whether you're going to end up going on that recovery phase or going down that end of life phase. Also, if your lymph nodes aren't involved, your treatment's probably not going to require more than surgery. But if they are involved, you're going to be requiring, probably chemo, different courses, and other treatments as well, possibly. So really, even from that point of view, it makes a big impact. What about other social determinants and things that can impact the cancer journey, more specifically the colorectal cancer journey? Well, actually, Redding in 2009 came up with the social determinants of Aboriginal, now I guess Indigenous health. This is a little bit of put together in just a slightly different ways than some of the ones that you're used to hearing of the regular social determinants. It's a little more holistic. It follows a medicine wheel teaching, which includes your physical, mental, emotional, and spiritual well-being. It crosses all stages of life, from infancy to adolescence, adulthood, and elder. It includes the patient, but also their community and their family. It includes not only the person, but their environment and the land and the animals and the air. So it's very holistic. And also an important distinction is that it's been divided up into proximal, intermediate, and distant. And to me, I think of the distant as the disease. I use diabetes as the disease, and the proximal the proximal social determinants as like a symptom, like a diabetic foot ulcer. So, if you have a symptom, if you have a diabetic foot ulcer, you can treat it, and you probably should treat it with some antibiotics, with some wound care, and it'll probably get better. But unless you actually treat the disease, the diabetes, and the sugar, get the sugars under control, that ulcer is going to continue to come back, right? You can throw tons of resources at that foot ulcer. You can use negative pressure, silver impregnated sponges. You can use very expensive IV antibiotics, and it'll get better still. But once again, unless you treat the diabetes, it's kind of all fruitless. But I do suggest that we try to treat some of the symptoms. It's important to keep people's symptoms under control, but unless we address those distal social determinants, a true equitable healthcare system will not be attained. So let's start off with some of the proximal social determinants, these symptoms. And these include health behaviors, including alcohol, which smoking, substance use, poor diet, lack of exercise. Wow, guess what? 4 of those are risk factors for cancer. Next, we have in the proximal social determinants, we have this 4, I always think that they're all interrelated, right? Education, you don't get a good education, you don't get a good employment, and a lower income. If you're not making much money, you can't buy good food or have a good physical environment, house over your head. And all of these things just become a really vicious cycle. And, physical environment in the cities and urban areas, that generally means homelessness. In rural and remote or northern communities, it often means overcrowded or with poor ventilation. Some also have very poor sanitation and waste. And, doing even the poo on a stick test would be kind of hard in these isolated and overcrowded conditions. Or if you're homeless, how do you do the fit test if you're homeless in Toronto? Where do they send it to? Where do you, perform that test in a clean environment? It is better than the old FOBT test, but it's still hard. And how do you even prepare for the colonoscopy to work you up? Let alone if you start in the cancer journey, which, like I explained, is not often one operation and done, right? It's multiple visits, often 3 to 6 months of chemotherapy. If you're dealing with all of these other things, it's hard enough to keep up with your screening, right? People don't want to think about their FIT or their pap smear or their mammogram if they're worried about where their next meal is coming from. Those visits aren't really high. So even getting onto the journey is hard, but then even once you're in that journey, it's even harder because with these lack of these supports in place, it's really hard to be compliant with very long and arduous treatment plans. Then there goes the intermediate social determinants of health, and these often includes healthcare and educational systems. As you know, Indigenous peoples are considered wards of the federal jurisdiction, wards of the state. This goes down to the Indian Act. Yet healthcare and education are provincial jurisdictions. This often leaves Indigenous people in limbo. There's often very difficult to get. Some communities have a lot of nursing and wound care and things available, or travel into town for their hospital visits or chemo visits, but some communities don't have those things. And then some, even home care here in my LIN that extends from Scarborough, Oshawa, Peterborough, not really rural, not the most rural areas. And it's often hard to get home care to go into some of these communities. And we've had to make memorandums of understanding. And that's how come Jordan's principle is in place now, right? To ensure that there isn't bickering over who's paying for these things while someone either gets sicker or doesn't get the care they need. Also, the cancer journey, once you're given that diagnosis, it doesn't only affect you. It affects your family, it affects your community, your surroundings, and it doesn't just affect you physically. Going through this is definitely emotional and mental, we finally see the recognition of that in our cancer care. And here in Scarborough, we started to have mental health assessments of nearly everybody going through the oncology clinic. And some people need more extra supports, others need less. And we do those determinations because they're starting to see that the cancer journey is more than just about physical wellness and treating the cancer. It's about treating the whole person, right? And that's a very Indigenous concept, actually. If they added emotional and spiritual health, they would actually attain a medicine wheel, and maybe one day the healthcare system will. But we know that for mental health, which is definitely affected by a colon cancer diagnosis, that cultural continuity is protective. If you have knowledge of your culture and your language, that actually is protective against depression and against suicide. That's been demonstrated from studies in BC from the 1990s. So, having a strong cultural attachment, a strong family attachments during the cancer journey is protective for Indigenous patients and probably for all of your patients. And this is where we get to the distal or distant social determinants of Indigenous health, the real disease. And this is why I had mentioned residential schools and the Indian Act, because colonialism is #1 on the list for things that actually impact care. Indigenous people, because of this, still face racism and social exclusion. And if you don't believe there's racism in the healthcare, let me just name Brian Sinclair, Joyce Eshkawan, the lists go on and on of Indigenous people who go into the healthcare system with seemingly very easily treatable conditions and don't leave the institution. So it doesn't only lead to poor care, it actually leads to death. So, we've seen, and lots of Indigenous people feel this and feel just from the whole colonization effect that leads to intergenerational trauma, which to me in a subset of patients really ends up leading to a constellation of symptoms, which is similar to PTSD, which often is aggravated every time they enter an institutional setting. So there is a good 10% of Indigenous people who will actively try to avoid institutions, healthcare settings, places that we think people should feel comforted and safe to go into, they actually feel the opposite. I've actually had to, join Indigenous friends of mine and bring them to hospital appointments because they did not feel comfortable going for a simple checkup. This wasn't to have a major surgery or undergo chemotherapy. And then just the way Indigenous people have been excluded from the history of the last 400 years, that lack of self-determination is actually considered one of these social determinants. So giving Indigenous people back their voice and allowing it to be heard, and not only heard, but listened to in their cancer journey is very important to Indigenous people. So because the acts of colonization and those residential schools, and that's what they studied during the Truth and Reconciliation, a lot of their calls to action are actually based upon those distal social determinants, whether we recognize it or not. And so these are, their calls to action are actually based on distal social determinants. And what they acted upon the people in the healthcare setting to do is to, they do number 22, 23, and 24. 22 is to those who can affect change in the Canadian healthcare system, to recognize the value of Aboriginal healing practices and use them in treatment of Aboriginal patients in collaboration with Aboriginal healers and elders when requested by Aboriginal patients. So a lot of words there, but actually it's very important, the distinctions that are made there. It's that when there are Aboriginal patients who want traditional medicine to be incorporated in their treatment plan, that we should allow it. And it's not that in Western healthcare providers, that oncologists or surgical oncologists should be learning traditional medicine, but they should not, they should allow traditional healers to become involved, and that they're the experts on the traditional part of it, not the oncologist. We also call upon all levels of government to increase the number of Aboriginal health professionals working in the field. That's probably beyond the scope of you guys, but at least at this point, but maybe one day. But it is important for all of us to consider providing cultural competency training for all healthcare professionals, right? Anybody that walks into the system can be affected by the care, and it doesn't matter if the doctor or, it can be then is trained and has a good interaction. If their interaction with the nurse or the pharmacist or the social worker or even the security guard at the entrance is negative, the whole thing is off, right? So really, it's treating everybody involved in healthcare should have some kind of cultural competency training. And it's not only training, right? It has to become an action. But anyway, we'll talk about that a little more. We also talk upon all medical, nursing, and really interprofessional health schools in Canada should require all students to take a course dealing with Indigenous health issues, including the history and legacy of residential schools, the UNDRIP, treaties, Aboriginal rights, and Indigenous teachings and practice. It's not only to be didactic, right? This requires skill-based training in intercultural competency, conflict resolution, and anti-racism. So those are the things that are actually already outlined out there in the TRC. Let me note that it's like 6 years since the TRC came out. Still, a lot of these things are really still only in their infancy, but it is important if we want to bring the two worlds and allow people to survive and for Indigenous people to be thriving in our Western medical model, right? This is the case, I thought maybe I'd taken this out, but I guess I left it for you guys. It's not a colorectal cancer case. Unfortunately, it would go better maybe in your next system, but the point is, this was to what I was just saying about people that care in the care of, but it is a care of a cancer patient. Actually, it's a 15-year-old Indigenous female in hospital for chemotherapy, leukemia. Patient and family are distressed with symptom management and with the food. And, I understand pain management for oncology patients, especially pediatric, very important. I'm distressed when I see the food in my own hospital sometimes. There are things we can do for that. But the patient and family were given permission to perform a ceremony in the solarium, which seems very nice. And I don't know what they did, if they did drumming or smudging or singing. But they went and they did their ceremony, and on the way back to the room, they said the nurse, but I don't know if it was a PSW, whoever was pushing the wheelchair, said to the young lady, "So now you think you're cured." Then the patient reconsidered continuing with the Western medical management plan. So, I don't know, but it would not be considered acceptable if someone was standing outside the chapel of my hospital and heckling everybody that walked out, saying, oh, now you think your mother's cured. Oh, is that going to do it? As they walked out of the chapel, right? That's essentially what they were doing here. It is totally unacceptable. And if that's what you get when you're going for care somewhere, I don't blame them for not following the model. And you know what the Western media said? Oh, Indigenous mother refuses daughter chemotherapy. Well, this is what the system was giving them. They were already trying the chemotherapy, but the chemotherapy and the care given to them was so atrocious that they couldn't take it anymore. So, so here's just to the point of traditional medicine. It follows the medicine wheel. It involves the patient, the family, the community. It has many forms: songs, drumming, smear, a prayer, smudge, ceremony, and a few where there's going to be medicines made into teas or something you consume, or a salve that you put on your skin or somewhere. And only a few of those plants could ever interact with chemotherapies, and very, very rarely would interact with your blood so much that you couldn't perform surgery. So really, why this can't be involved in the care management of most of our patients is really a mystery to me. It's partially because it's been demonized in our society. A lot of these songs and ceremonies were actually outlawed in the 30s to 50s. It's really practiced by experts, people who do apprenticeships for tens of years, decades, and it's really unlikely to interfere with our medical interventions. And we should note that 60% of Canadians, not just Indigenous Canadians, but all Canadians seek alternative medical practices for the management of their medical problems. So, our biomedical model, the majority of Canadians feel they have to go beyond that to truly treat themselves and feel that they're getting the full care they need. So some of the other things we can do to provide proper care is learn how to be culturally safe. And culturally safe refers to a state by which a provider embraces the skill of self-reflection as a means of advancing a therapeutic encounter with First Nations, Inuit, and Métis peoples and other communities, including but not limited to visible minorities, gay, lesbian, transgender communities, and people living with challenges. That's the Indigenous Physicians Association of Canada and Royal College definition. And really the key point is that it means taking into account your biases, right? And I want to say that, yes, there's lots of courses, there's lots of workshops. Well, maybe the workshops are shut down during COVID, but different ways to learn about cultural safety training. But really it's a practice and it's a way of interacting that one has to embrace and carry as they move ahead. And it's something that you're constantly working on. It's not like you take one workshop and, oh, I'm trained. It's not like you read a book on, karate and all of a sudden you're a black belt, right? Like this is something we have to do every day in every encounter. And that's with all our patients. I work in Scarborough. I have people from Tamil, Hindu, Muslim, like every different background. I'm not a member of those communities. I learn things culturally every day. And I try, just try to be humble about it. Also, how to be a true ally going forward, but and not be a liar. So a lot of us want to do good, want to be benevolent and well-meaning, but often that ends up being paternalistic and taking away true self-determination, right? To be an ally is not to come in and be the quarterback and get that touchdown. So I'm going to use a football analogy. I don't know how much everybody knows football, but if you're being an ally, it's time for Indigenous people to be the quarterback, to be the star, to be the one getting the touchdown, making the big reception, or essentially being the Tom Brady, right? To be making that play. The role of a true ally is to be a left tackle. Most teams, you don't know who the left tackle is. I can't even name, I love the Patriots. I don't even know who their left tackle was or is this year. But they're often the second most highest paid person on the team. And they're so important because their whole job is to make sure that the quarterback doesn't get sacked. And that is the whole job of an ally. It's not to be taking the praise, it's to be helping out and running that interference and allowing Indigenous people to succeed and to shine. Indigenous people aren't looking for a handout, they're looking for a hand up and for assistance to get to that touchdown. Also, being an ally means calling stuff out when we see it. And this is hard, and I failed to do it before, I'll admit. But how to do it without offending, right? It's easy to go and say something smart ass when you hear someone say something racist, but then you don't usually end up helping much because everybody just gets madder and madder, and it just ends up in a big argument, right? And you haven't really gotten anybody to change their point of view. But often a good way to do it is to bring up, why people are having that, why they make those false premises in the first place is a good way to address it when you want to bring it up. Like actually go to the core of those ideas and try to have them examine why they're actually wrong. The next point is that we want to form partnerships and fight against this paternalism. We've already discussed it a little bit. So this goes to some of the pitfalls, and we've made a bunch of these points already. Paternalism is a hard habit to break in medicine, and especially in surgery. Sometimes we do have a habit of, doctor knows best. Although I must say, in most care circles right now, I think most of us find our role is actually to give advice and let patients and families come to most of their own decisions. And definitely with Indigenous people, that's super important. As I mentioned earlier, a simple course or workshop may not make a person or program culturally safe. It's an ongoing process. A little bit of cultural competency may be dangerous. I've seen a lot of people who think they went and they flew into a reserve once, one place, and now they know everything about all Indigenous people, all the 600 communities across the country, all 1 million of us. I can tell you, I barely know what my brother's thinking. So, good luck if you figured us all out. It's very hard to make assumptions, and that there won't be one easy answer. If there was, I'm sure it would have been in place by now. And also, it's important going forward that we need to acknowledge and remunerate Indigenous knowledge as the wisdom that it is, and try to incorporate it into the care plans of our Indigenous patients. When we get into our leadership positions, because that's what a lot of Western healthcare providers are, they end up being leaders in their communities and their professions, is that it truly is an action, not a position. Too many times I see the leaders mandate that all of their workers get cultural safety training, but they haven't done any themselves. And of course, once again, they have to set an example and be leading that, right? And also giving up some of their power and letting Indigenous people be the ones that are shining in their organizations and providing the true leadership, not just in token roles, in token offices off to the side, but actually involved in leadership. So this is a picture of Attawapiskat. It's a small community on the edge of James Bay. They face, flooding on a regular basis. They've dealt with opioid suicide crises, as you can see, have some issues of their own. They've needed supports. Well, when Fort McMurray dealt with the forest fires, which is one of the highest per capita earning area codes in the country, when they had forest fires, the people from Attawapiskat raised $5,000 to send to Fort McMurray. So that's the spirit of Indigenous people going forward, and that we are still resilient and hopeful to make a better healthcare system for ourselves and everybody in Canada. So these are some of the things we can do going forward in healthcare. You can read it yourself. Cultural safety training, recognition. It's important to build relationships that recognize that the social determinants impact every aspect of wellness, including the Indigenous Cancer Journey. Building relationship, and this takes time with clients and patients. You're free to ask, don't assume. You should learn about general Indigenous culture, but also your local communities. And you should provide care from a culturally safe, strength-based, and trauma-informed space. Be a true ally, partner, and leader, and to respect one another, to get back to the spirit of sharing and friendship and peace. And thank you very much. If you have any questions, you can, after this, you can email the address up there. And now I'll go back to Jeff to see if there are any questions.
Yeah, thank you for the talk. There are a lot of powerful messages there. So first of all, I want to say congratulations to the gift card winner, who is Yvonne. And now I have some questions that did pop up. So one of the questions that I see here are, what are the greatest challenges in implementing some of these solutions and partnerships in the medical area to make sure Indigenous people feel welcome and accepted? I guess you did mention this in part, but if you have any elaborating comments.
Well, so I think there's a lot of things people can do with these relationships, but we got to remember, I think, that you have to get, if you're going to build, you know, I have people here at Scarborough Health Network keep saying, oh, just open an Indigenous health clinic. Well, that's not the right way to go, right? That's the U of T, sometimes ivory tower, Western mentality, build it and they will come mentality, right? Like you should be starting right from the get-go to going to the community and asking them, what do they need in a safe space, in a place that they're willing to access? So I think building that relationship from the beginning and getting Indigenous input from the beginning is the most important. I think, you know, making yourself accessible for Indigenous people, making your space, when you do start setting up that relationship and getting known in the community, because there's the Moccasin Telegraph, word gets around our communities, you know, that this is a good place, or they're a good doctor, or a nice clinic, people will come, but the word has to get out and that space has to be safe. So, you know, you see, I have some Indigenous digital artwork actually on my wall. Try to make your space safe. Or even, you know, the way the LGBTQ2S community sometimes has the rainbow triangle. Well, you can have a little medicine wheel logo too, right? Up in your office. It's not a pan-Indigenous symbol, really, the medicine wheel, but I think it is recognized across nearly all Indigenous cultures as something positive and healthy. Try to get, if you're going to use any of them, make sure it's actually attained from an Indigenous organization so that it's not appropriation, and you know, do it meaningfully if you want to state your place. But if you want to have Indigenous art or some kind of symbol from the Indigenous community, marking to make that place feel safe for your Indigenous patients. Having more flexible hours or accessibility to your place makes it easier for patients with disability. You know, Indigenous people are more likely to be on transit or have diabetes or to have accessibility issues. So, and having more flexible hours sometimes, but making your space, it's really, you know, about reaching out to the community and meeting them where they're at and finding out what they want, instead of just to say, oh yeah, they need a community, let's just put up our thing that we're having an Indigenous clinic, which is what the Scarborough Health Network sometimes seem to want to do. And there, no, we have to do a lot more groundwork with the community and ask them what type of clinic do they want, right? Once one of my colleagues, Lisa Richardson, who's an Anishinaabe Kwe internist downtown, was seen by a bunch of endocrinology fellows who wanted to study diabetes in 6 nations. And, you know, they've been studied diabetes up the wazoo, like over many, many years. So when Lisa told them, well, maybe you should go ask the community what they want to be studied, you know, what they want to have studied in the endocrinology realm. So they went and met with the community, and the community wanted to know more about their bone, about osteoporosis and bone disease. And they actually did the study and actually found some very interesting things that we didn't know before, whereas we know a lot about diabetes in Indigenous patients and probably wouldn't have gotten anything new out of the study. So ask the, you know, having the patients, having Indigenous people involved from the get-go is probably the most important thing. Sorry for being long-winded as usual.
No, that was a great answer. I think we're about like 1 minute away from the closing remarks. So I'll just take this last minute to thank you again, Dr. Pennington, for the entire talk. And thank you for everyone who joined us today. I'm going to be posting the link to the final closing remarks into the chat. And I've posted Dr. Pennington's email in the chat as well. So if you have any questions, feel free to contact him. All right. Okay, I'm gonna stop.